Welcome to Convergence, an historical assessment of kidney diseases, nephrology, and health policy in the United States. I'm your host, Tod Ibrahim, ASN Executive Vice President. Today's episode is Mr. Glazer Goes to Washington, the origin story of the Medicare end-stage renal disease program. This episode examines the obstacles early advocates overcame to secure financial coverage for dialysis for every American living with kidney failure since the early 1970s.
We need to have them dialyze before Congress. Let people realize that these patients are going to die if they lose their insurance because no one can really afford dialysis on their own, or rarely. Few patients have the wherewithal to afford dialysis.
That was Terry Litchfield, a longtime advocate for kidney health, along with her late husband, Bill Litchfield, who died in 2014. Terry worked for the National Kidney Foundation and met Bill, one of the first dialysis patients in the United States, in 1968. A dialysis patient for most of his life, Bill was among the patients who testified before the House Ways and Means Committee in support of legislation to expand Medicare coverage for dialysis. Terry, what were some of the existing efforts for coverage at that time?
There were many activities. American Society of Nephrology, the National Kidney Foundation. There were efforts across the country. They had what were called red shirt days, where instead of having like firemen with the boots, these were kidney patients collecting money to help people that weren't covered or who had gaps in coverage, or if they maybe couldn't pay their water or their electric bill for home dialysis. All of the patients understood that U.S. Public Health Service funding of the equipment and the supplies and your home unit was a grant, and it was going to expire. And so it was like their life had an expiration date. So they were highly motivated. They had really a very strong advocacy program because they had started, the original patients started in Seattle, Washington. But these were patients, they were all working patients, but they all knew that they were in jeopardy of the ending of the public health service grants, which was set to sunset in 1972. And so none of them really had the money to pay for dialysis. And insurance companies, with the exception of Blue Cross Blue Shield of the United Auto Workers in Michigan, it was Blue Cross in those days, no other insurance company in the United States paid for dialysis. They considered it experimental. The patients had this great idea that they would go to Congress. And in those days, the Senate committee, particularly Wilbur Mills, encouraged members of the public to come and give testimony. And this was when Medicare was being discussed and the whole idea of national health insurance was on the dockets. And they decided that this was something that was really important.
So, on November 4th, 1971, another member of the advocacy group, Shep Glazer, who was also living with kidney failure, insisted on dialyzing while testifying to the congressional committee. What led up to that moment before the House Ways and Means Committee?
There were no dialysis centers in those days. So they actually got on the hearing docket, and it was very controversial because it was a stunt, really. And the doctors were afraid that something untoward would happen. You're dialyzing in a Senate office building. Something bad could really happen, and it could have totally devastated their efforts to get coverage. But it didn't. And so the four of them went and they were heard. He arrived, and everyone immediately said, "You've got to change his mind. Shep is going to dialyze," because they had a somewhat understanding that they would show the access, to show them their access sites, and they all had external Scribner shunts, and really talk about what it's like and give their family life. And then Shep said, "No, I'm going to dialyze," and they argued a bit over should he or shouldn't he. And Shep said, "I don't care what anybody says. I'm going to dialyze." And so they ended up getting a borrowed kidney machine over from Dr. Schreiner's. They started out, and it was just like any other hearing. And then they were setting up the equipment, and they had to run the dialysate, the cleansing, had to go out of the window of this beautiful Senate office building. They plugged it up, and then he showed. They all gave testimony. Shep rolled up his arm, cannulated, and dialyzed briefly. And it was, Bill said, you could feel how momentous it was. He didn't know it was momentous, but he said you could feel the tension in the room when it started and then relief when it was over. And they all worked. When they went back a few weeks later, my husband always laughed because the dialysate that went out the window etched that beautiful limestone building because it was an acetate dialysate bath, and it killed all the foliage, he said, for about 10 feet.
What's interesting is I started my career working for a member of Congress in the Longworth House office building, which is where the Ways and Means Committee is located. I can picture exactly what you're describing. Although the dialysis session only lasted a few minutes, it left a lasting impact. Doing a medical procedure in front of the committee must have been a very dramatic moment. How do you remember the committee's response?
Disbelief after it ended, that it seemed so simple and that this was people like us. He remembered one of the senators who came and said, well, you're just like we are, just regular people. You had the dialysate, you had to mix it yourself and use conductivity meters. I mean, it was early generation. And then, the dirty fluid would have to go out of a window, or in the home, it would go down the sewer. But they were very rudimentary and not as accurate, certainly not as accurate as a computer generator. A lot of hydraulics and a lot of things that we don't have today, like air embolism detectors and things, safety features. But
So,
it was brief. It was a brief dialysis, but it really did in the press releases. And they had a media, AAKP had a media conference afterwards. And it really allowed people, decision makers, congressional decision makers, to actually see that people could continue to work.
since June 2001, Chip Kahn has served as president and chief executive officer of the Federation of American Hospitals, the national advocacy organization for tax-paying hospitals. Chip is the only healthcare leader to appear on Modern Healthcare magazine's annual 100 Most Influential People in Healthcare list every year since its inception nearly 25 years ago. Chip has a long and distinguished career as a professional staff person on Capitol Hill, specializing in health policy issues, and he has contributed to shaping virtually every piece of national health entitlement and health-related tax legislation.
For people who aren't familiar with how Congress works, particularly how it worked in the early 70s, just curious if you could help us understand the sort of House Ways and Means Committee and why it was important to this discussion, and then the Senate Finance Committee and why it was important to this discussion.
Well, revenues and healthcare entitlements go together. That was the case from the 30s when Social Security was developed during the Roosevelt years. And the Ways and Means Committee was in the House, the centerpiece for that. Both Medicare and Medicaid came out of the Ways and Means Committee originally in the mid-60s. The revenues to fund Medicare came from action in the Ways and Means Committee. And before sort of the revolution of, I'd say 75, but when the young Democrats came in the post-Watergate period, and also Wilbur Mills, the long-standing chairman of the Ways and Means Committee, ran into personal problems, which led to him leaving Congress. Ways and Means, later on, beyond 1974, was weakened, but in the years between Medicare and 74, it was in the House, the centerpiece of dealing with financing and delivery. And then the Finance Committee had then and still has jurisdiction over the major entitlement programs, Medicare, Medicaid, now the Child Health Insurance Program, other entitlements.
So one of the kind of formative moments in the history of nephrology is when a patient named Shep Glazer tried to dialyze in the hearing room for the House Ways and Means Committee in the Longworth House office building. And we've talked to some people who witnessed testimony from people who were there. But I'm just sort of curious, is that a story that you've ever heard? Or I'm just sort of curious as to how you think that would affect a committee hearing around thinking about how to expand health care, and in Kennedy's case, sort of this proposal of Medicare for all.
Let's separate this from the overarching health coverage, because I think this was a specific event. Yes, obviously I've heard about it. I didn't come to work on the Hill till many years later, but it was a point in time in which you had a disease and you had mitigation for that disease, and you had death if you didn't get the mitigation. So it was a severe case of survival, and it didn't matter whether you were 65 or 64. If you had these kidney problems, you really had no choice but dialysis. Ultimately, you get to transplantation, but at that point, there was no choice but dialysis. And that's the way it was presented to the committee, the way it was presented to Congress. And it's interesting to me if you look at the response of Wilbur Mills. Wilbur Mills took this very seriously. He and his committee had great sympathy for these individuals that suffer from the kidney disease, but at the same time, he was a conservative. And even when he had done Medicare and Medicaid, and particularly Medicaid, which is a shared program between the states and the federal government, he was concerned about expenditures and about the potential for growth in costs. So you had the hearing, and then about a month later, you had a bill that he put in that would have appropriated money for a program for these people, would have provided support for them, but it would have been capped. Payments would have been limited. The details aren't as important now to say that it was not an entitlement. It was a program, like other government programs, that people would have to seek, be eligible for, but it wasn't written into the law as an entitlement. Now, I'll go back to the Finance Committee. You brought up the Finance Committee. In the Finance Committee, Senator Long, chairman of the Finance Committee, had a different view at the time. And ultimately, when dialysis became covered, it was covered by Medicare. We can go into that further if you'd like. But the important thing here is that I see that as sort of a subset of an evolving exploration of what's going to happen with Medicare. At the time, some people may have saw this as a precedent. As it was, I don't see it as a precedent. I think it really was a one-off, because I'm sure a lot of the policy people at the time thought the last thing you want to do is go illness by illness for those under 65, and you get into issues of, in social insurance, you still want to have insurance covering a specific population with an illness. It's not insurance, it's social insurance, but it's not insurance. There were a lot of arguments and concerns about it, but the condition was so compelling that Congress acted. But I also think that Congress looked at it and said, well, we're probably not going to do this again. And it never has happened again.
So a couple of really interesting points you're making that I haven't heard anyone else articulate before. I mean, one is this idea that if Wilbur Mills had been successful and treatment for kidney diseases, particularly treatment for kidney failure, was more of a discretionary program where Congress each year had to appropriate funds, theoretically there could have been more flexibility where, especially if insurance started to cover a lot of the costs for dialysis, you could imagine it may be looking a little bit more like the response in the war on cancer, where you start to make a huge investment in NIH research and other sort of discovery to try to advance toward a cure. That's sort of one path we could go down. The second path is this idea that I think in the popular history, there's a thought that the Medicare ESRD program was described as kind of the camel's nose under the tent, which it was going to be the first disease state covered by an entitlement, which was what happened on the Senate side with Russell Long. And instead, that hasn't happened, and there hadn't been sort of subsequent diseases covered or therapies covered, which is another path. So there's sort of two interesting moments in history that come out of this in the early 70s that, if you think about nephrology from the perspective of 2025, has really driven how the specialty has evolved over those 50 plus years.
I mean, yes, there's no question when Congress sets up a program, whether it's an entitlement or other program, it does have a tremendous influence on the shape of how the program is dealt with in the real world by patients and physicians in the system generally. I think that dialysis, though, and these particular kidney and the kidney mitigation, that it provides is sort of a unique situation. I think when you get to cancer therapies and other therapies, one, there's a lot of evolution over time, particularly with cancer. There's a lot less assurance that the therapy is going to work for everyone. Whereas I think dialysis ended up being a one-off because that disease may have worked in a sense in terms of placing it in the model. Also, the program's become, it's a very large, expensive program. I think as Congress saw that happening, there was, regardless of the compelling nature of any other illness and really suffering group, I think Congress looked towards bigger solutions than the sort of one-off approach.
I mean, it's interesting too, because if you look at policymaking over the last 50 years around the ESRD program, it's almost all been cost containment, to your point, as opposed to thinking creatively about how to make the program more effective or potentially to expand it or to move it in different directions. You mentioned the cost, and I've been interested in how much Congress missed or failed to anticipate how the costs would grow. And at the time that the legislation was passed, the thought was this program would cost about $100 million a year. By 1980, at the end of the Carter administration, it was over $1 billion a year, which put it interestingly at the same level as the funding for the National Cancer Institute. This is from a book by a prominent nephrologist named Chris Blagg, who was involved in all this, but I thought this was just an interesting sentence from his book. He says, "The main public reaction came on January 14th, 1973, about 3 months after passage of the legislation, when the New York Times attacked the kidney legislation as irresponsibly broad in an editorial titled Medicarelessness." And that really struck a nerve with me in the sense that it was almost like from the beginning the program was seen as irresponsible to kind of what the overall goals were for Medicare. So almost the opposite of setting a precedent for other diseases. And I'm wondering, just given your history in Washington and your understanding of Congress and health policy, how did things change from a policy perspective as the 70s moved into the 80s? And we sort of think about sort of how both the Carter administration and the Reagan administration engaged with Congress on health reform issues.
This particular change was a one-off, and it became clear within no time that that's how Congress would consider it. And what ended up happening, obviously, the occurrences of Watergate and the other controversies around the winding down of the Vietnam War, there were a lot of things going on in the mid-70s that I think put healthcare more in the back burner, other than, I can't remember which year the HMO Act passed, whether it might have been 73 or 74. But what you found when Carter came in was he went in two routes regarding this. One, he did a national health insurance bill so that he would have one. But his national health insurance bill combined private-public, which put him at odds with Kennedy. Kennedy was still on Medicare for all. And ultimately, that was an issue in the ultimate campaign when Kennedy ran in the primaries against Carter, when Carter was seeking a second term. But Carter made a decision that you've got to deal with cost before you can deal with access in terms of the legislative process. So he really pushed hard on Carter cost containment, which primarily capped hospital costs. It had some other aspects to it, but it primarily focused on hospital costs. And that was, for a couple of years, I came to Washington in 79, it was still going on, but in 78 and 79, that was the focus of Capitol Hill. And there was a great controversy over that. The bill never passed at the end, even though they had fairly big majorities in both the House and the Senate. It was controversial in the Democratic caucus in the House. But so the focus was on cost containment. Then Reagan gets elected, and then the focus was on the entitlement programs that existed and how to contain costs there. And that's where in the Tax Equity and Fiscal Responsibility Act in 82, There was provisions regarding capping hospital costs. And then in the following year, in the Social Security amendments of 83, you got the diagnosis-related groupings, which went to sort of a capitated payment for hospitalization, which hospitals supported because they were so worried about the caps that would have gone into effect under the TEFRA law. And that began a whole generation of reform of Medicare payment. Physician payment was ultimately reformed, other aspects through the 80s and into the 90s. The focus was on how do you contain costs on the Medicare side, and then on the Medicaid side, there was a creeping of coverage engineered by Henry Waxman, who was chairman of the Health Subcommittee on Energy and Commerce, which now had jurisdiction over Medicaid. The Ways and Means Committee lost that jurisdiction after Wilbur Mills. And there were expansions of Medicaid and the development of the child health program, but no sort of general national health insurance. Now, there was a discussion and an attempt in 93, 94 with Clinton and with President Clinton, Mrs. Clinton. I encouraged Congress to pass a private-public national health insurance, but that failed. And that was sort of the one blip until you get to 2009.
If the ESRD program had become a discretionary program instead of entitlement, then a lot of what happened in the 80s, where the focus was on controlling the costs of the Medicare program and the Medicaid program, it's sort of interesting to wonder if there would have been some other direction. I know it's impossible to speculate, but it just seems like this was a program that was created perhaps not with the most strategic of intentions. And now, again, it's driven how the specialty has evolved over the last 50 years. And its formative years, if you will, in the 80s was mostly a time of cost containment to the program, and it always being part of those discussions. I'm curious as to your reaction to that observation.
Let me say this, and I was working on the Hill in those years, and there were a number of budget bills, and each budget bill had some kind of Medicare provisions with targets to reduce the growth in Medicare spending. And I wouldn't separate out dialysis. It was just, you looked at every line item in Medicare, Medicare Part B, aspects of whether it was hospital care or post-acute care, home health, you were looking for areas where you could have savings. And dialysis was just one of those areas. There was a lot of discussion over time with secondary payer, with dialysis of people that have other private coverage or eligible for private coverage, and who would pay for dialysis. Obviously, during those years, the cost of dialysis grew dramatically as the cost of Medicare generally did. It was just part of the milieu of this, let's take every piece of Medicare and look at how we can deal with the cost increase. There were general strategies later when we get to the attempts by Republicans to put managed care into Medicare, and then ultimately that really has taken off. Medicare Advantage today is over 54% of Medicare in terms of beneficiaries. But that all comes later. The focus in the years in the 80s was really on what can we do in a fee-for-service environment to deal with all these different pieces of the program.
So that's interesting. So you really saw this almost like a line item activity as opposed to a kind of program that should be managed as a program.
Let's go to 1995 when I was a staff director on the Health Subcommittee on Ways and Means. The Budget Committee gave us in 95 a command that said we needed to save $270 billion from the program or find ways to cut spending that much in over a 7-year period. And so I looked at different pieces of the program as the staff person responsible for at least designing the first drafts of what we would present to the members to reach that goal. I went sort of piece by piece. And the same was true prior to that. Through all the budgets that were done during the 80s, there was a budget bill almost every year that dealt with Medicare as well as taxes and other entitlement programs, Medicaid. And there were always 20, 30, 40 Medicare provisions in these bills dealing with each little piece of the program. That reform period was really a period of, I won't call it micromanagement, but hyper-management by Congress of the aspects of the program. And dialysis was just one of them.
Was there ever any discussion about means testing, the ESRD program?
Well, there was frequently discussion about means testing or income relating aspects of Medicare. In 1998, the Medicare catastrophic law was passed. It was repealed in 89, and that's a whole story unto itself. But there was some income relating in terms of the funding of the new drug benefit that was put in place in Medicare catastrophic. I don't remember any specific discussions around dialysis, but I'm sure that it was one of the areas that was thought about in terms of income relating. The income relating was really a more general discussion, and it was primarily obviously coming from the Republican side, although Medicare catastrophic was unique. It was many years later that we have income relating in Medicare today. But actually, you make a point. I think in terms of premiums and premium payment, that the thought has been more to generalize it, even if you income related, but generalize it across Medicare, not to pick out a program or an aspect of Medicare or a population within Medicare. I can't say there was never any discussion about dialysis being income related uniquely, but I think the discussions were generally broader. Generally, the discussions of reform on the beneficiary side and the benefit side have been across the board, not focusing on a particular aspect that would disadvantage any particular group of beneficiaries.
C.J. Blagg is my neighbor in Arlington, Virginia. An attorney who's married to a Foreign Service officer, C.J. is also the son of Dr. Christopher Blagg. Dr. Blagg, who died in 2022, was executive director of Northwest Kidney Centers for nearly 3 decades, including during the formative years of the Medicare ESRD program.
It's interesting because I've had a chance to read his book about the establishment of Northwest Kidney Centers. And it's entitled From Miracle to Mainstream, Creating the World's First Dialysis Organization, Early Years of Northwest Kidney Centers. And about midway through the book, he starts talking about the effort to create the Medicare ESRD program. And so in the fall of 1971, the House of Representatives, through its Ways and Means Committee, had a series of hearings, and a number of nephrologists and people with kidney failure were able to testify and make the case. And it's interesting because it's pretty clear in the book that your dad thought it was really important for nephrologists and clinicians to join with patients to advocate for initially, care for people to be provided universal coverage for if they had kidney failure through dialysis and, as you know, with home dialysis. But then as he continued to advocate as the program was established, and it still had to function. And so it sounded like that was the part where he got really involved with,
yes,
how do we make this a workable program to provide the highest quality care possible? What's your recollection of that experience?
I think it's a good point. He was not, I don't think he was necessarily instrumental in the enactment of the ESRD. That wasn't his push, but where he got really involved in the later years, he spent a lot of, and he loved this actually. It was as part of his job. He had sort of drifted away from medicine, and he became a bit of a lobbyist, if you will. He spent a lot of time in Washington, starting probably in the mid late 70s, all the way to his retirement. And he would spend time in Congress trying to educate staffers and the members of Congress about the importance of the program. It's something he loved. I mean, he just loved that role. And I think, again, part of it tied to he had a real love for the United States. Maybe one of the things, some immigrants, he was an immigrant and he really appreciated the democracy. And so he loved spending time on the Hill. And again, it was about maintaining the program, making sure things didn't get cut, all that sort of stuff. And that became a huge focus of the latter half of his career, for sure.
One of my favorite parts of the book, and it connects a couple of things, is that at ASN Kidney Week, we have a Blagg lecture in your father's honor, and it focuses on policy issues in nephrology, and it's co-sponsored by Northwest Kidney Centers, the Renal Physicians Association, and ASN. And I didn't know this, but in the book he talks about the first meeting that led to the establishment of the Renal Physicians Association. And I'll just read it because I think it's so wonderful. He says, this is 1973. An angry meeting was held at O'Hare Airport in Chicago on Black Friday, July 13th, attended by some 40 nephrologists from both private practice and academia. This led to the formation of a new society, the Physicians for Renal Replacement Therapy, later to become the Renal Physicians Association, to protest the regulations related to nephrologists and to work with the Medicare program to improve the regulations generally. So I think there's a number of wonderful things in there. One is just the fact, the original name and how it evolved. The second is the fact that it was the academic community and the private practice community coming together, which I know was really important to him. And the third, and I think the most important, is the fact that it was the nephrologists trying to improve the program and recognizing that while government has a role in terms of establishing the program, it only functions if the experts, in this case the nephrologists, are there really pushing to improve things as much as possible.
Yeah, I think that's right. I know he sort of talked about the government is a bit of a blunt instrument, and so the funding was great, but then how things actually got applied in terms of regulations in the program, that's where it deals in the details, and that's definitely where the expertise of the nephrologists and the nephrology community came in to be very important.
An origin story explains the initial events and defining moments that shape an identity or a purpose, or in this case, the Medicare ESRD program. In the end, Congress didn't pass legislation to create the Medicare ESRD program because Shep Glazer dialyzed before the House Ways and Means Committee. Congress created the ESRD program because Senator Russell Long, who chaired the Senate Finance Committee, failed to convince his colleagues to include prescription drug coverage in the final version of the Social Security Amendments of 1972. As a compromise, Congress opted to include the ESRD program in the legislation because it was considerably less expensive than drug coverage. Then President Richard M. Nixon signed the Medicare ESRD program into law on October 30th, 1972, and every American has had access to dialysis starting on July 1st, 1973. Since then, this program has ensured life-saving therapy to more than 1 million people. This podcast should not be used in any medical emergency or for the diagnosis or treatment of any medical condition. If you have any questions about any medical condition or before taking any drug, changing your diet, or commencing or discontinuing any course of treatment, please consult your doctor or another qualified healthcare professional. Views expressed on this podcast are those of the speakers and not necessarily those of the American Society of Nephrology.